The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome, TMD Warriors. I'm Tony Urbanic, and we are gathered here for the next episode of TMD Demystified. Today's topic is entitled Screening for TMD. Now, this is a very important topic, or I hope that you look at it as a very important topic. Hopefully, by the time I finish in 20 or 25 minutes, you will agree with me that what I have to say may be very beneficial to you and your patients. But the title again is Screening for TMD. Now, if you have thought about treating TMD, or you see patients with TMD, or someone you know has TMD, your familiarity with it is primarily associated with someone making it obvious to you that they have TMD symptoms. Maybe they have been going around in circles about this for years or decades. That is very common. That is very, very common, as you know, for people to go from doctor to doctor or to one doctor many, many times trying to treat and figure out this thing that we call TMD/TMJ. However, it should be apparent that if you have a really significant disease process that happens in a huge number of people, the prevalence is very, very high, it might be beneficial to screen for the problem before the patient begins having significant symptoms. You know, I've talked so much on this and I'm so familiar with it, but the symptoms, I mean, all this is common sense and can be accepted empirically. The symptoms are so common and they overlap with other diseases that have similar or identical symptoms is one of the reasons, not the main reason, but one of the reasons why TMD has not been addressed properly by certainly the dental community or by the medical community, because the symptoms, when they appear, are most often confused with other diseases. That is why in the past, and maybe in the present, you know, TMD has been called the great impersonator. And I had a episode that I entitled TMD, the great impersonator, and that whole concept is not true. TMD doesn't impersonate any other disease. The problem is that the TMD symptoms overlap with other diseases that have similar symptoms. So it's not an impersonator for other diseases. It is just confused with other diseases more often than not. So, and the most common one we'll just speak on, as I have so many times, when a person has a bad recurring headache, immediately, one way or another, whether they get the information from their PCP, the convenient care clinic physician's assistant, the internet, or the television, they immediately assume that the patient has migraine headaches. And then they go down that dirt road treating migraine headaches using drugs of various kinds, which are not effective or if have any effect at all, have significant side effects, and basically numb the nervous system. Just not, one way or another, that's what you are doing with migraine drugs, whatever type of drug you are using. You're literally diminishing, suppressing parts of the nervous system so that your pain is suppressed, doesn't treat the problem. Think about that a moment. And that is extremely common. So doesn't it seem appropriate, doesn't it seem logical that you might, if you are a network, you are a healthcare provider, that you would want to screen for this problem before it gets out of hand for the patient, and if possible, alleviate their whatever symptoms they may have and avoid significant damage to the joints and significant symptoms which sometimes are not correctable in the future. Stands to reason. So there is a lot to say about screening TMD. Now, dentists are not used to screening problems except unless they are dental decay and periodontal disease, and we do an excellent job of screening for these two problems. That's why you have a checkup every 6 months, ideally. Not everybody does that, but in the ideal scene, we ask our patients to come back every 6 months for a checkup. Well, what is that checkup? It's a screening. It's a screening for periodontal disease and dental decay. And once you get past, an initial x-ray somewhere along the line and you screen for impacted wisdom teeth and you screen for whatever orthodontic care may or may not be necessary, those things are actually screening techniques. But the major thing you do every 6 months is screen for decay and periodontal disease. Well, wouldn't it be just as appropriate to screen for a problem that occurs in 45% of females? 45% of females have temporomandibular joint symptoms of one kind or another between ages 13 and 75. I say that with authority. Most of the articles on the prevalence of TMD can go all over the board between 15% of the population, 30% of the population, but those articles do not include all the symptoms. They just include the symptoms that the patient complains about, which is, earache, pain in and around the jaw joint. Headaches are included, but they don't include all of the symptoms of tinnitus, subjective hearing loss, vertigo, upper back and shoulder pain, arm, hand, finger tingling and numbness. Most of the articles don't include those symptoms. When you include all of the well-known, well-established symptoms of TMD, the number approaches 45% of the female population, nowhere near the number of males, but it's pretty much 90% female problem, 10% male problem. So there's a great number of males who have TMD. Today in this office, we did 3 consultations for TMD. 2 of them were males. So screening for the problem is a very good thing to learn about and to do. It's a big problem. We already talked about that. 45% of females. If you do the multiplication that 45% of females and half the population in the country is females, that's 76 million women in the United States have some degree of TMD symptoms associated with the causes of TMD damage. Causes of TMD damage and chronic inflammation are bruxism, acute trauma, and functional malocclusion. Those are the 3 causes of chronic inflammation. So it's an easy screen. It's actually an easy screen. We'll get into that in a minute. So TMD, as mentioned, is often misdiagnosed. It's often misdiagnosed by the physicians as migraine headaches, Meniere's disease, ringing fullness in the ears and dizziness, and chronic ear infections. My God, so many patients that I've seen recently have had PE tubes put in because their ENT doctor came to the conclusion that the solution was PE tubes because of their ear pain, when actually it was TMD causing severe ear pain, or the patient felt like it was ear pain, which the PE tubes did not solve, but placing the patient in a non-surgical device that unloaded the temporomandibular joints over a long period of time protocol, alleviated all their symptoms, including their ear pain. So it's often misdiagnosed. Now, who is going to do these screenings? If you're going to screen for it, well, who's going to do it? Well, I may enlighten enough physicians where they start screening. It is definitely possible that through educational processes to the medical community, that enough of the medical community will actually start screening for temporomandibular joint problems, like they screen for heart disease, lung disease, diabetes, on a routine basis. Wouldn't be a bad idea, but that would put the dentist to be in a very embarrassing position if you actually had the physician screening for TMD. Doesn't it make more sense if the responsibility is taken by the dental community to begin screening for this devastating disease that affects 76 million women in the United States alone? Patients don't know where to go when they have some of these symptoms. They do not know where to go. If you are an average patient in the United States of America and you have ear pain, and that is your only symptom, you're going to go to either your PCP or an ENT doctor. And again, I can tell you just hundreds and hundreds, if not thousands of cases here out of this practice where those patients were misdiagnosed as something else when it was actually TMD. Patients have no idea. So you can't expect the patients to do their own screening, for sure. I mean, if they have a problem with dizziness, if they have a problem with subjective hearing loss, sooner or later they're going to end up their ENT doctor. And of course, some of the ENT doctors here in Middle Tennessee are very enlightened now, and we get huge numbers of referrals from selected ENT practices. They're not all enlightened, but the ones that are enlightened easily pick up several patients a week to send in for TMD consultations. So really the issue is, how do you determine if a patient has TMD and what the definition of TMD is, which is nothing more, nothing less than inflammation within the temporomandibular joint. And if you can diagnose this inflammation early and put the patient, if necessary, into a treatment protocol where they will not get further deterioration of the temporomandibular joint, further inflammation of the temporomandibular joint, then you've done the patient a tremendous service. You don't have to wait until they start locking. Locking is one of the last symptoms to show up, and a patient who presents to this practice with locking of various kinds of the temporomandibular joint has been suffering symptoms of other kinds of TMD for decades, at least 10 years, or if not 20 years, if not 30 years. Now, again, wouldn't it be logical to save your patient decades of pain, discomfort, and dysfunction by doing a little screening process that alleviates the symptoms and alleviates the inflammation, which over time causes irreversible damage within the joint? And once it's irreversible, it's irreversible. The damage is done. We can relieve the symptoms no matter what the joint looks like on X-ray, but the patient had gone through decades of pain, dysfunction, and problems, symptoms with that joint. So screening is a very appropriate thing to do. And who should take the responsibility? The dentist should take the responsibility. And it is so simple. I mean, it literally takes a few minutes, and I say a few, 3 minutes, for either the dentist or especially the hygienist. And if you train your hygienist to do a simple screening process with every patient, I promise you, you're going to uncover hundreds of patients in your own practice. And then using simple enlightenment educational programs, marketing programs, you can enlighten the physicians and the nurse practitioners in your area easily. There's nobody else to do it but the dentist. I mean, I can tell you that even with the greatest amount of education, the physicians are not going to screen for TMD. So first of all, how do you screen it? I've talked about this before. How do you diagnose it? It is too simple. The proper definition of TMD should be, and it isn't now, but I recommend it become, proper definition should be inflammation within the temporomandibular joint. If you have chronic inflammation within the temporomandibular joint, that is TMD. And it's irrelevant where the disc is, how much damage to the disc, how much bone loss is on the condyle, how much enlarged is the glenoid fossa. Those are observations as the joint becomes damaged, but you shouldn't diagnose and you shouldn't define TMD on those standards. The standard is very simple. If you have chronic inflammation in the temporomandibular joint, you have TMD. The patient has TMD. Now, if you have TMD, chronic inflammation, over short or long period of time, it will create symptoms. So symptoms are the red flag. So there's two parts to a diagnosis: a screen, which is collect symptoms, and then do a very simple physical examination to determine whether there's inflammation in the joint. You don't have to draw blood. You're certainly not going to get it off of a Panorex, a plain film, or an MRI or CT scan. You can't see inflammation on those studies. However, if you have any number of the following symptoms: frequent or recurring headache, earache, jaw pain, neck pain, ringing in the ears, tinnitus, subjective hearing loss, fullness in the ears, dizziness, vertigo, upper back and shoulder pain and tightness, arm, hand, finger tingling and numbness, and various kinds of locking, you have red flags saying this patient may have TMD. At which point, if there's a suspicion, then simply all you have to do is have the patient open their mouth widely, press firmly into the opening of the glenoid fossa, and have them bite quickly, one time. If it hurts, they have chronic inflammation. If it hurts, it's inflamed. If it hurts and inflamed, they have TMD. That's how long it takes to screen for TMD. Ask, do you have or have you ever had any of these symptoms? If the answer is yes, you have red flags. Say, wow, this might be TMD. At which point you do this. And if it hurts, you've made your diagnosis. You screen for the problem, at which point then it's up to you and the patient to define the problem, to offer assistance, that there is a solution, and more importantly, avoid problems in the future. Now, if you wear a device that separates the back teeth according to protocol, I promise you the chronic inflammation in the joint will go away sooner or later. And the protocol is 24/7 for the first 2 months and nighttime only or sleep time only for the rest of your life. That handles 95% of patients and their symptoms if they follow that protocol correctly. So the treatment is very, very simple. The diagnosis and screen is very, very simple. And not only can you offer the patient relief of their current symptoms, but more importantly, as we get into more sophisticated areas in our development of our healthcare system, screening for problems before they create significant damage is much more important in our healthcare system than it ever has been. And the dentists need to take their part in that, besides screening for dental decay and periodontal disease. This particular problem really is the linchpin that connects dentistry and medicine. There is a huge outflow right now. There's a huge push to bring dentistry and medicine together. A huge push to integrate dentistry and medicine. More often than not, if you're not familiar, there's significant effort on this part, by Pacific Dental and Stephen Thorne, to actually integrate dental offices and convenient care clinics together, and to integrate the healthcare system so that both the physician and the dentist work together, the screening of a patient to elevate their level of health care. Again, with 76 million women in the United States having this problem, there's no limit to the number of people that you can help. Hygienists are the very, very best opportunity to do the screening. You don't even have to do it when you bring your patient into the office by the dentist. You know, the dentist, the hygienist cleans the teeth. She takes a few x-rays. She's looking for periodontal problems and the depth of pockets, looking for decay, screening for that. Well, why not take an extra 90 seconds and screen for TMD? And then leave it up to the patient whether they want to treat it or whether they want to treat it to avoid problems in the future. Whether the majority of people with TMD, the cause is bruxism. Not all, because the other causes are functional malocclusion and acute trauma, but those two causes of chronic inflammation in the joint are in the minority. The majority of cause is bruxism. And as our society gets more and more on edge, as the stresses in our society almost on a daily basis get increased, I find that more and more patients are complaining of bruxism and the obvious signs in the mouth of abrasion and tori and lateral exostosis and sort are becoming more and more apparent. So even as time goes on, it's becoming more and more of a problem. So integrating dentistry and medicine, there's a move afoot to do this and gives you the opportunity to do it yourself, instruct your hygienist to do a very easy 90-second screen for the problem, and then if appropriate, treat the problem or treat the problem to alleviate future episodes and symptoms in the future. It's really obvious, and I think that now is the time that we need to make that change in our profession. TMD is an obvious linchpin to connect and integrate medicine and dentistry. If you want to do your part as a healthcare provider, as a very important healthcare provider, you are literally and should be considered the physician of the oral cavity. You should be the physician of the oral cavity. You know, the specialties of medicine are many. You can think for yourself about how it's divided up among the physicians. Well, you literally are the physician of the oral cavity and shouldn't limit yourself to treating teeth. Let me say that again. You shouldn't limit yourself to just treating teeth. I think you're much better educated and should have a higher consideration of yourself and consideration by your patients, for sure. With that being said, I think I've made my point. I hope I made the point. If you'd like to comment on this episode, please contact me at tony@tmjservices.net. If you'd like to criticize me, same email, tony@tmjservices.net. If you'd like to join the network of doctors who use this device to treat TMD to a high degree of success rate, if you'd like to see our independent university study, which proves what I just said, what I claim, that 90+% of patients who use this device and protocol can get the result. It's just a tool. If you learn how to use the tool, you'll get the response. If you'd like to join the network, you can actually do that and take the appropriate course at www.urbanictmj.com. Learn how to do it for your patients, screen your patients for TMD. It's a lot of fun to help these patients. It does not take a lot of time. You do not have to be a TMD expert. You do not have to have extra degrees to significantly, successfully treat TMD. That is a fact. You do not have to be a TMD guru to treat TMD. Let me hear from you. I'd love your comments. I'd love to hear your comments. Until next time, which will be next Tuesday, it's when I do these episodes. I look forward to the next time that you tune in, listen to an episode on TMD Demystified. I am Tony Urbanek.